Hi, my name is Susan Elliott, and I'm a nurse practitioner at St. Louis University School of Medicine. I work in the Division of Geriatric Medicine, and this presentation is on deprescribing in older adults. There is a companion video out there for polypharmacy and inappropriate medications in older adults, so I would recommend viewing that as well because they kind of were meant to go together. A disclosure, my university is funded through HRSA via a GWEP grant, which is a Geriatric Workforce Enhancement Program grant. Part of my salary is supplemented. The objectives of today are to list 2 resources for deprescribing, list a reason for deprescribing a statin, a reason for deprescribing a blood pressure medicine, and a reason for deprescribing an anti-dementia med. So why should we deprescribe? The problem is large. The CDC did a long study from 2009 to 2016 where they analyzed 2 billion visits of older adults and found that 36.8% of the visits had 5 or more medications, which is polypharmacy. Of those, 70% had at least one potentially inappropriate medication. The PEM prevalence in primary care is nearly 1 in 5, 19%. Nursing homes, nearly 1 in 3, and hospitals, almost half. When we look at drug-drug interactions, severe ones, the prevalence in nursing homes is 3%, followed by primary care 4%, and hospitals at 29%. Hospital admissions were analyzed from 1988 to 2015 in a large meta-analysis and found that 8.7% of admissions were associated with a potentially inappropriate medication. 1 in 10 adverse drug reactions leading to admission is from an NSAID. AMDA has an initiative called Drive to Deprescribe, whereby they want to increase goal-based care and reduce polypharmacy and reduce the scheduled medications with a goal of 25%. They have evidence-based podcasts, and it's a wonderful resource. They provide rationales to support why they're doing what they're doing and how to do it, most importantly. They have downloadable resources. They hit on the meaningful categories that you see here, which include anti-hyperglycemics, anticholinergics, the anti-anxiety meds, the anti-dementia meds, anti-hypertensives, statins, aspirin, the whole bit. Another excellent deprescribing resource is deprescribing.org. It's headed up by the Brewer research team. In 2023, they created a repository for clinical practice guidelines that use the grade strength of evidence to support rationales. And again, they also go over how and when to deprescribe. They have the downloadable resources, and they hit also on meaningful categories, including PPIs, the blood pressure medicines, the sugar, the anti-diabetic meds, the anti-anxiety meds, the cholinesterase inhibitors, including memantine. So a word about prescribing cascades. That is when you prescribe a medicine to fix a side effect from a medicine. So the med list grows exponentially this way. A review in 2022 showed some of the common cascades. So a loop diuretic to treat the edema caused by a calcium channel blocker, say amlodipine. I ran into this just yesterday. So it's a very common occurrence. We should be on the lookout for fixing prescribing cascades to reduce polypharmacy and inappropriate medications. Other ones include levothyroxine to treat hypothyroidism caused by amiodarone, the allopurinol to treat gout caused by amio, the NSAIDs to treat the myalgias caused by statins, and then there's a few more here. And my personal favorite here is at the bottom. So I spent a lot of time caring for residents in long-term care, and they'll be on a laxative because of their constipation. And then suddenly they'll develop some diarrhea, and the nurse will call out maybe after hours, and they'll say, hey, so-and-so has diarrhea. Can I get a anti-diarrhea medicine, say loperamide? And then the provider is going to say yes, because nobody mentioned the fact that they were on a laxative. And so now that's probably one of the most common things that I see. So I try to fix that every time I see it. Dementia risk increases with polypharmacy. So in a systematic review and meta-analysis done in 2019, more than half the patients were on 5 or more medicines, which is the definition, the most accepted definition of polypharmacy. And it's strongly associated with increased risk of dementia, as you see here. The risk goes up with excessive polypharmacy, so greater than 10 meds. It was noted that when a geriatrician was on site, polypharmacy decreased. So anti-dementia medications have cholinergic effects of their medicine. So the anticholinergic medicines that might be prescribed are working against them. So what we see is constipation, delirium, cognitive impairment, and urinary retention. None of those things are good in our demographic. When we combine beta blockers or calcium channel blockers with the cholinesterase inhibitors, say your donepezil, which is, some people may know it by the name of Aricept, you actually get an additive effect or synergistic effect. So we see slow heart rate, syncope. They really shouldn't be prescribed in people that have sick sinus syndrome or known heart block. And then the antipsychotics, when they're combined with the cholinesterase inhibitors, have an antagonistic effect again. And what we see with these is that people develop the rigidity and the Parkinsonism and the extrapyramidal effects. So we need to be on the lookout for reasons to deprescribe the anti-dementia meds. So some of the reasons you see here in the blue box include risk versus benefit, having a lack of response, severe cognitive function, or a functional decline. We'll speak more about this in the next slide. So this is an algorithm that was downloaded from deprescribing.org, which I mentioned earlier. And you'll notice the two purple boxes at the bottom is basically everything leads to potentially trialing a deprescribing action for the cholinesterase inhibitor or memantine. And over on the left side, I've summarized it here in the blue box. So if a person's had worsened cognition or function in the past 6 months, they're not realizing a benefit. If they have advanced dementia, so consider your people on your locked units, if you work in post-acute long-term care, who need help with their ADLs, and if they have a limited lifespan. So really looking at the big picture with this. A word about supplements. In 2022, the task force reviewed the evidence and found insufficient evidence to recommend a multivitamin. But in addition to that, if you look over on the left here, a large study of 8,000 participants who were followed through time for a long time. This study was done in 2022, resulted for the vitamins A, D, E, C, B9, and B12. They found that whether you were in the high or the low group of vitamin, that all of the ones that you see here are significantly associated with all-cause mortality risk. So it doesn't matter if you're taking a multivitamin and you're contributing to maybe lifting a level above the normal range, that's as bad as being low. The only vitamin that was correlated with a reduced all-cause mortality risk, including with cancer, is vitamin D. So the moral of the story is, if they need to have a repletement done to get them back into the normal range, that's fine. But we don't want people to be high, and taking a multivitamin adds to that. Taking B9 and B complex and vitamin C when you don't need it is not just not needed, it's bad. So it increases the risk of mortality. Deprescribing one medicine in polymedicated hospitalized stroke rehab patients actually increased nutritional and protein intake, which contributes to their ability to participate in the rehab in the first place. So very good outcomes with that. When we look at the aspirin guidelines, back in 2016, the AHRQ reviewed the evidence and found that adults on primary prevention who were less than 50 or more than 70, so the more than 70 or more is who really applies to our demographic, there was insufficient evidence to recommend an aspirin as preventative because of the bleeding risk. If we're looking at 81 milligrams versus 325, and you're dealing with a person with secondary prevention, 81 was found to be as effective as 325. So if you've got a person with a history of a stroke and they come in on 325, the dose should be lowered to 81. There is a small benefit for the people who are 60 to 69 years old to have primary prevention with a baby aspirin, but the risk is so close to the benefit that it really should come down to patient-centered care. When we look at sliding scale insulin, used as a monotherapy is not recommended. You see here that the ABIM, AMDA, the AGS, the ADA all agree that it's reactive medicine. It does not contribute to diabetic control. It requires painful sticks. It increases low blood sugar, and we see a really labile response. So sugars that go from really low to really high. So dangerous outcomes with that. Antipsychotics have had a black box warning since 2008 because of the increased risk of death in people with dementia. In the most recent update of the Beers criteria, which I discussed in the previous video, the emphasized language is added not to use antipsychotics for dementia and delirium. Both were increased significantly, the use of, since and during the pandemic. So be on the lookout for that. I think when I spent my time in post-acute long-term care, almost everybody that came from the hospital after they had COVID were on an antipsychotic. So I was stopping them like crazy. PPIs are a big problem, proton pump inhibitors, so things like omeprazole. They're available over the counter. People seem to stay on them forever. Really what needs to happen according to the guidelines is that after the initial 8-week treatment, they need to be stopped. Sometimes stopping them in a taper works better, so going every other day, or maybe starting an H2 blocker while you get rid of the one might help you be more successful at that. But really a person only needs to be on an ongoing PPI if they have esophagitis, grade C or D. We need to be using the lowest effective dose. Sucralfate is not recommended in the guidelines, so if you see people on that, that's something you can stop. And then prescribe it before dinner versus at hour of sleep. And I was unaware of this before I read the guidelines, but it actually has a higher efficacy level. Statins are something that people are scared to deprescribe because they don't want someone to have a bad outcome. Most of the guidelines, based on age alone, will require that your older adult be treated with a statin. And the guidelines, when they do say it's okay to deprescribe, they use unclear language like consider or it's reasonable. And even when they do say these things, they don't provide how to stop a statin. So back to the previous resources that I talked about with the AMDA's Drive to Deprescribe and deprescribing.org, who actually do show you how to deprescribe. The reasons, when we looked at the evidence of the guidelines all put together, that they will recognize the fact that it's okay to maybe stop a statin would include being in poor health, frailty, shortened lifespan, multimorbidity, functional decline, and time to benefit. And we'll see here in a minute that time to benefit really makes a big difference because some of our older adults don't have the time to benefit. It should be considered through a shared decision-making and a geriatric model of care. So in the previous video, I talked more about the 4 M's of age-friendly healthcare, which include what matters most to that person: medications, mentation, mobility. So looking at how prescribing affects all these things is part of being a good steward of medicine. A little bit more about statins, the time to benefit, a major acute cardiac event or a MACE. So in a review in 2021, a meta-analysis, it was identified in adults 50 to 75 years old that it took 2.5 years to prevent one major acute cardiac event or a MACE in 1 out of 100 older adults with no benefit of mortality. When we looked at actual deprescribing, in the pink box here below at the bottom, the primary prevention people, when we deprescribed the statin, they had one extra MACE in 1 out of 112 people per year. And then in secondary prevention, there was one extra MACE in 1 out of 77 older adults per year. So the little box with the red heart is 1 in 100, just to give people an idea that these are the statistics and how long it actually takes. So when you consider your older adult that might have, say, 2 years to live, and by the way, most nursing home residents live less than 2 years. Most people, community dwelling people with dementia, live 1.7 years or less. So consider these people when you're looking at statins on their drug list. Not to mention the fact that they might have side effects like a decrease in weakness in their legs, and they can't transfer or walk like they used to, and it's affecting their activities of daily living, which really contribute to their quality of life. Looking at blood pressure. So what is over-controlled blood pressure? I personally see this a lot, but the Partridge study back in 2015 looked at 80-year-olds in nursing homes, and people with a systolic pressure less than 130 who were on 2 or more BP meds were significantly associated with increased mortality. The hazard ratio is 1.78, so you can see it was almost twice. And then this was even significant after it was adjusted for cardiovascular comorbidities. So the moral of the story here is that being over-controlled is not being safe. So it's an opportunity to deprescribe a medicine. When we look at the optimized trial, which is a non-inferiority trial, meaning it works as well as, and they examine deprescribing versus usual care in 80-year-old plus people on 2 or more medicines. The deprescribing arm was non-inferior to usual care, meaning that it wasn't mandated that a medicine be stopped. So when they had, the particular sample had people with systolic less than 150. More than half the people did sustain the reduction, and then the average change was only 3 points on the systolic pressure. Another study done in 2018, so just a little before this one, looked at providing mentoring versus usual care, and the mentoring was on deprescribing. So of course the deprescribing arm was a little higher. They did see a slightly higher increase, transient increase in blood pressure. So it was 15 points on the systolic, which did come back to baseline at 9 months, back to a mean of 138 millimeters of mercury. So overall, deprescription had no effect on heart rate or systolic blood pressure. In fact, the group that did not receive the mentoring and did not have the higher level of deprescribing had increased hospitalizations. So this is an algorithm here by Shepard et al. In 2022 who looked at all the guidelines, and this is on deprescribing hypertensive medications. And I summarized it again in the orange box here on the right. So really, if someone is 80 plus years old and they've got a systolic of less than 150, or if they're 75 to 79 and their systolic is less than 140, we need to be looking at deprescribing. We need to do it in reverse guideline order. So the green box at the bottom on the left-hand side, you'll see some of the agents at the top, like a loop diuretic is the first to go, followed by beta blockers, thiazides, the ACE inhibitors, and then the calcium channel blockers. They found that the calcium channel blockers were more associated with having a transient increase in blood pressure when you stop them. So When we stopped beta blockers, that was not seen. We do, however, need to be careful of rebound hypertension or rebound heart rate going up. So doing these slowly over a 4-week period of time, one medication at a time, is what's recommended. So here's a case to test our knowledge. It's an 81-year-old white white male. He's had some falls, hypertension, osteoporosis, and B12. Here for a routine visit. His only complaint is feeling a little fatigued. So the question is, which medications would you taper and or stop? And here's the vitals and the medication list. I'll let you pause on this and give it a thought, and then we'll move on to the answer. The answer is folic acid, simply because it's not indicated when a person has B12 deficiency, but really lisinopril. So we chose lisinopril over the amlodipine in the reverse guideline order based on the Deprescribing algorithm because the systolic pressure was less than 130. And here's another case, 84-year-old white female with advanced dementia. She's had a recent SLUMS exam of 9 out of 30. She has some hypertension and falls. She's here with her daughter today for a routine visit, who also takes care of her, and reports that now she's not recognizing family. So what medications would you taper or stop? Here are the vitals and the meds. I'll let you pause on this. The answer is a multivitamin, polypharmacy, vitamin C, polypharmacy, over-the-counter memory supplement, absolutely, because it's not FDA regulated, number one, and number two, it's most likely a stimulant. Her D3 is good, her lisinopril is fine based on her vitals, but really the anti-dementia meds at this point we should be paying attention to. So the donepezil, which some people know as Aricept, and then memantine, which some people know as Namenda. So these medications, if she's having a decline on them, indicates that they're really no longer effective. And while you can stop donepezil right away, you really need to be tapering on the memantine. So I would go down by dose slowly on that until it's gone. That's the end of my presentation. I hope everybody got something out of it. If you have any questions or comments, you're welcome to reach out to us here at the Gateway Education Center. Happy to share any resources. Thank you.